I'm Natalie Benamou. I am the founder and president of HEALTHX. I'm delighted to welcome you here today for this important conversation that we're going to be talking about women's heart health. I can't wait for you to hear all of the things from our experts that we are going to be speaking with. We have Dr. Simi Lee, who's going to be speaking about, we're going to have a fireside chat with her about all the things that you can do for your heart. And then we have patient stories that are so important that we want to make sure you hear from. We have Saraa Basaria and Patty Jasek that are going to be talking about their heart health stories, and Priya Bhathija, who is with New Health that we are partnering with for this important conversation. And I want to share a little bit about HEALTHX. We're a very new nonprofit inspired by our own experiences with medical gaslighting. And if any of you have had any of these things happen to you, it's not in your head. And we're going to be talking about this and why it's so important for us to know medical gaslighting. 5 years ago, I started getting curious and asking women if they had ever had something like this happen and hearing these types of things. And over again, almost 99.9% of the time, I heard yes and a story. And so medical gaslighting is when a professional, medical professional, dismisses or downplays a patient's concerns or symptoms or attributes them to something else, such as a psychological condition, or it can be being told that you work too much, you're too stressful, many things, check off the box, that can result in a delayed diagnosis and treatment. HEALTHX got started with the foundation of trying to make a change. We want to improve women's health outcomes. And in doing that, we are collaborating and partnering, and we want to bring the whole ecosystem all together so that all of you and all of us can make change happen. If you're interested in learning more, please reach out to me. We would love to partner with you in any way, whether it's being a partner or helping us with our research protocol that we are kicking off with a health system. We would love to have you help us with our mission, which is to change the way women experience healthcare. We strive to create a world where women are heard, respected, and treated with dignity and compassion. And that is so important in today's world. And I can't wait for this conversation so that you can hear how women are taking what is happening with medical gaslighting and taking action. So with that, I'm going to pass the baton over to Priya Bhathija with New Health and the conversation so that you can have a chat with our guests today.
Great. Thanks, Natalie. And I'm so happy to be here and be part of this conversation. Through New Health, we are working in a number of ways to improve access to health and healthcare for women. And we have an educational series as well, which Natalie always participates in religiously. And we covered heart health in June, and it was a really enlightening conversation. And Natalie and I wanted to just keep it going and expand that. So Natalie, thank you for putting together today's event and including me as part of the conversation. And I am excited to start the conversation today talking about patient experience. This is something that is very important as we think about heart health and women's health as a whole, and will be a great way to ground the conversation that we have today on heart health. So I am joined by two women who are willing to share their experiences related to their heart health. And I don't want to take up more time from them, so I want to get started. Saraa Basaria is our first panelist. Saraa, and I'd love to turn it over to you to share more about yourself, what you do in your day job and in your life, and what happened in your personal heart health journey.
Sure. Thanks, Priya. And thanks for the opportunity to both you and Natalie for joining this panel and having this really important conversation. So I met Priya through our day jobs, or her former day job as a lawyer. I'm an attorney in Boston. I've been practicing law for about 12 years now. In 2022, when I was 34 years old, I had just started a new job and I developed symptoms of what I thought was a bad sort of bout with food poisoning. couldn't keep anything down. I was getting pretty weak and pretty run down. And knowing my own health and knowing how healthy I had been to that point, I went to the doctor pretty quickly, and over the next 6 weeks went to several doctors. I went to gastroenterologists, I went to ENTs, I went to urgent care several times, I went to the emergency room twice, and each time my symptoms were downplayed. I was told that I have a stressful job, so of course it must be anxiety. I would tell them I'd been practicing for a law for 10 years by that point, and that sort of, didn't make a difference. My symptoms weren't taken terribly seriously. I mean, I really felt as if the medical professionals I was dealing with at that time were sort of like, you have a tummy ache, it happens to people. And sure, it does. But, I think when you have somebody who's saying, there is something really wrong here, I know something is really wrong, and you're not getting sort of any real response to that plea that you're making to medical professionals, the only choice you have is to just zealously advocate for yourself, which is really difficult when you are very, very ill. I luckily have a sister who lives in Boston as well. So I had someone to come with me to appointments to help me advocate. Eventually, my parents came up to Boston. At the time, they were living in Florida. And through a lot of advocacy, I finally got myself admitted to the hospital. And very shortly, within 48 hours of that admission, I had my first echocardiogram where I learned that my ejection fraction was 8, which is a very, very low ejection fraction. A typical ejection fraction is between 55 and 60. Mine being 8 meant that I was in end-stage heart failure. When my family was told this news, they were told that I may not make it through the night. I was admitted to the critical care unit pretty quickly, and it was very touch and go for me for about 3 weeks. At the end of those 3 weeks, sort of in between that time, I was told that I would need a heart transplant in order to continue living. That the presumably virus, which cause is still unknown, but what doctors think happened is that I got a virus and I had what's called viral myocarditis, which attacked my heart. The damage had been so severe and had been so prolonged before any intervention, any medical intervention, that there were no more options for me other than a heart transplant. But getting a heart transplant, as you can imagine, is difficult. And so my only option was to get what's called a left ventricular assist device. It's an internal and external medical device. It is implanted via open heart surgery. Part of the heart is amputated and a cylindrical pump is put in sort of at the bottom of the heart, and that functions as your left ventricle. That pump needs power, and so there is a wire that comes out of the patient's abdomen, and that wire is attached to batteries. Batteries have 17 hours of power every day, weigh about 10 pounds, and every night the patient charges their batteries and they plug themselves into the wall so that they have power for their heart to pump overnight. That was my journey for about a year and a half until the sort of fall of 2023. After doing a lot of work to keep myself as healthy as possible, I learned that the sort of routine testing that I had looked a lot more positive than expected. And through more rigorous testing, I learned that I was in remission from end-stage heart failure. I no longer needed a heart transplant in December of 2023. My LVAD was decommissioned, meaning all the external pieces were removed. The internal piece is still in there, but it's off, and I have my life back.
So I have known you for a long time, Saraa, so saw you living through this. And the last time everyone that we sat on a panel together, she was actually on her LVAD, and she sent an email to all of us saying the good news when she was doing better. And I just remember sitting at my computer and crying because it's like such a horrible experience. And I think, I think that you not being heard and having to advocate for yourself is probably the part that I think is sort of the hardest to hear when you share your story, because had you been listened to and had you been heard early on, you might not have gotten to where you needed an LVAD or to be on the transplant list. And I'm just so thrilled that you had a positive outcome. And I still think it's a miracle. So thank you for sharing that. So Saraa, it's like your example is sort of a classic example of medical gaslighting, in my opinion, right? So what did you have to do to be taken seriously and to be heard with your medical providers? And based on that experience, what do you recommend that other women do as they're approaching their own health, not just heart health, but health in general?
Yeah, it's a great question. And, I first want to say I so appreciate both your words, Priya, and Natalie's as well. And, it is sometimes difficult sharing my story, but I think that there's so much value in sharing things that happen to us so that other people, other women know A, that they're not alone, and B, can be empowered to advocate for themselves. And the answer to your question is that is ultimately what I had to do with a really strong team behind me. So my sister, who I mentioned, lives in Boston. She's also a lawyer. So we're both advocates by nature, or sort of by both nature and professionally. Eventually when my parents came up as well, I think being relentless in what you know about yourself is really important. I always say, you know you better than anyone else knows you. I can't tell you how many times I've been in a medical setting, even before this, for sort of run-of-the-mill things, right? And you'll talk about a symptom you're experiencing, and you might hear a medical professional say, well, that's not supposed to happen, or that doesn't sound right to me. As a patient, you want to say, obviously, that's why I'm here. That's why I'm talking to you about it. If it were normal, we wouldn't be having this conversation. And I think we, especially as non-medical professionals, tend to be very deferential in a situation where we are dealing with medical professionals. And of course, I understand the reason to be, but you can be respectful and have a sort of cordial relationship with your providers while also knowing what you know about you and not letting anyone else convince you otherwise. Oh, you're on.
I think there are a lot of pressures that come with practicing medicine in 2024, right? So physicians are challenged in terms of the time that they're able to spend with you, given that there are obligations. And there are just natural challenges associated with lack of education around women's health. And that starts from the core of lack of clinical research around women's health. And so when we have this conversation around medical gaslighting, and you mentioned it and Natalie did as well, like, it's not to be against doctors, it's really to set all of us up to have the right conversations and the right relationships with our clinicians, where we can ask questions and we can be heard, and there can be a back and forth about what is needed. So thank you again, Saraa. And Patty, are you up and live?
I think I am finally. I'm so sorry. My internet was giving me hassle. So I signed out and signed back in. So thank you.
Yeah, no worries, Patty. And if you could share more about yourself and your experience, that would be great.
I'd love to. Thanks for the opportunity to do this. So mine started with a history that my brother had a calcium heart scan, and it showed that he had almost a full closure of his LAV, or his LAV, his left ventricular artery. And so they were offering at the hospital that I get my treatment at a calcium heart scan for $59. And now calcium heart scans are not reimbursed as of yet by any insurance company. But because of my brother's problem, I thought, well, gosh, and I do have a maternal history of heart attacks, although they all lived well into their 70s or late 80s, but the heart attacks did occur. So I thought, I'm just going to get this. And so I did. And the score came back at 806. The calcium heart scan score only goes to 900. So it showed that I had significant coronary atherosclerosis. Sorry, that's a hard word to say. And so then Okay, so then I got put on, immediately put on an anti-cholesterol drug, and then I also had to see a cardiologist. I was very lucky and very different from Sarah in that I prompted this healthcare. I then prompted the healthcare system to take care of me, and I got in to see a great cardiologist in Chicago, Dr. Batty, and so he did a full workup on me. It's noted to say that I had no symptoms. I was overweight, and still am, but I have lost 40 pounds in the last 2 years since diagnosis. But the deal was that it would have been silent, a silent killer, where I would just have a heart attack and not even know what was happening. So after the calcium heart scan, I had a heart stress test, I had an echocardiogram, and I had a CT of the heart and a CT heart analysis. And all of that ended up that I had currently have an injection fraction of 58%. So anything over 50 is okay, but it's still close to 50, so it's still scary. And then I do have almost a 68% blockage of my LAV, which is the same artery that my brother had that full blockage on. So I felt very lucky and very cared for. I got put on a statin, I got put on an anti-cholesterol drug, which is a statin, and then I got put on a hypertension drug as well. And have lost weight, which is really great, and need to continue to lose some more. But my story is very different from Sarah's in that I asked and entered the healthcare system voluntarily and then got connected with the right people who absolutely met my needs and were very helpful. I remember we were going down to a concert at Millennium Park, and it was like 7:30 in the afternoon, and that's when the cardiologist called me to explain all my test results. It's sort of like, he's like, are you doing okay? I'm like, well, I'm at a concert, so I think I am. And so now it's really the fact that I have to be very cognizant that if I have any symptoms, I have to immediately, call the cardiologist, or based on the symptoms, go to the emergency room, knowing that I have this history and this disease.
Yeah. So Patty, your story is very different than Sarah's, and through it, you advocated for yourself, you asked for the therapy. What advice do you have to everyone who's listening as they think about their own heart health and where they may be? Because your brother's situation prompted you to take action. How can you prompt others to take action for their own health?
Well, I think there are multiple resources out there, and the first one is to know your history. So, make sure that you understand your medical history, make sure you understand your parents and your grandparents' medical history, because those are risk factors that could put you at risk for that. So my side of the family has no hypercholesterol risk, but I noticed that mine was slowly creeping up. And that is really important. So you should actually understand what your lab values are. If you're not getting an annual physical as a woman, start there. That's the first thing that you need to do, is get an annual physical, get all of the blood work done and the analysis, and really start to look at what is health and what part of health do you want to do. Go Red is a wonderful organization, I think we're going to talk about a little later, that has wonderful resources for women with heart health care. But it's important because if your heart's not working, then you're not working. That's one of the issues that takes place.
Yeah. Yeah. Thanks, Patty. And for both of you, even though your journeys were different, and Sarah, I'll start with you. What do you wish you would have known before all of this happened?
It's a great question. I think the big thing that I wish I would have known is that heart failure can happen to somebody in their 30s, and it can happen with no sort of warning or, really for no reason. My heart failure currently is in remission, but also diagnosed as idiopathic, which means spontaneously occurring. I wish I would have known that an EKG is part of routine care when you go to something like the urgent care or an ER. I didn't have my first EKG until 48 hours before that big echocardiogram that I had. If I'd had an EKG even 2 weeks prior, would have shown quite a few abnormalities, and the ball would have started rolling, and maybe I wouldn't have needed an LVAD.
Mm-hmm.
So I think education, I think particularly around heart health, now that I do a lot of heart health advocacy, one thing that I learned through my involvement with Go Red, my sister and I were actually co-chairs of the Circle of Red for Go Red for Women in Boston. this year. And so I read up on a lot of their stats for a lot of the speaking engagements I was doing. And the most surprising stat that I've learned is that cardiovascular disease is the #1 killer of women, more than all cancers combined. You know, sort of just as a layperson, a non-medical professional, if you would have asked me what's the biggest sort of medical killer of women, I would have said likely breast cancer or some sort of reproductive based cancer. It blew my mind that cardiovascular disease is so high up there. It also blew my mind that there were other people my age that were experiencing it. So I think increased education to women is so necessary. And with that increased education, whatever we can do to empower women to, as I said, just be relentless about their care.
Yeah. Thanks, Saraa. And Patty, your thoughts?
I would totally agree. I mean, I really think that the importance piece here is that you understand your own symptoms and you seek preventative care as well as system care if you have some kind of symptoms. And oftentimes, and I think this was spoken about by Saraa and perhaps Priya and Natalie, women ignore their symptoms. You know, we're too busy taking care of others to take care of ourselves. And we don't think that these symptoms are important. You know, so it's little symptoms. Like if there's a change in something that you've been doing and all of a sudden you're short of breath when you walk around the block, that's important. And it's something that's concrete that you then need to seek medical care for. And if you don't find someone who will listen, then change your physicians. You know, there are tons of physicians out there, and we want someone who wants to be our advocate and actually walk with us, not someone who tells us what to do.
Yeah. Well, thank you, Patty. And Saraa, I think that's a great note for us to end on. We appreciate you sharing your stories and your experience and also sharing with all of us what we should be doing in our own lives. Thank you again. And Natalie, I'll turn it back over to you.
Thank you. And thank you, Saraa, for being with us today. Thank you for sharing your story. We appreciate you being here. And, you know, thank you for inspiring us to know your story and also just all the ways that all the things that you had to go through is really important for people to know. So thank you very much.
Thank you all
for
so much.
joining us
I really
today.
enjoyed our conversation.
We're going to talk a little bit about what women need to know and the disruptive thing that you're doing with your practice. I can't wait for people to know, but we've heard a little bit about patients and two different scenarios. And myself, I'm going to share one really quick story about my heart health journey because I think this is relevant. My mom presented with a heart attack, went to the ER. And so this is something really important for all of us to know, that the equipment 20 years ago couldn't diagnose women's heart attacks. It was calibrated for men. So she was sent home and told that it was her gallbladder, and she got gallbladder surgery. And the very next day in the hospital, she had a massive heart attack and was 90% blocked in her main artery. So misdiagnosed in the ER because of the testing, but also her symptoms were dismissed. She had, you know, pain, you know, all the symptoms that she presented with. And they said, well, the test came back okay, it's your gallbladder. She had 4 more heart attacks and then passed away from a stroke within 5 years. And we know that statistically women die within the first 5 years after a heart attack. And so I'd love for you to share a little bit about how we can be more cognizant about our symptoms and what we should know. Because I think that's important for us as patients and caregivers.
Well, first of all, thank you so much for having me here and for sharing your story, you know, on the heels of 2 such powerful stories about heart disease in women and also just self-advocacy, recognition, awareness. So really sets a great tone for this part of the discussion. And everyone's making, you know, I see some people are making good use of the chat. I hope we sort of hear more stories or see questions that come through there. But as Natalie said, my name is Dr. Simi Lee. I am a cardiologist based in Boston. I've developed over the years a special interest in women's heart health, really inspired by the experience that I had during the COVID-19 pandemic, or at least as we emerged from it, just seeing so many women coming back very, struggling with many heart health problems, at the intersection oftentimes between weight and heart health, because there's such a really, close link there with weight gain, worsening risk factors, and some had their first events like heart attacks or strokes. And so it really just drew my attention to this issue and some of the unique considerations around getting women access to care, appropriate recognition, starting to try to come up with a way to deal with underdiagnosis, widespread underdiagnosis and undertreatment. And so I still maintain a very small part-time practice at a Harvard-affiliated hospital in Boston called the Brigham and Women's Hospital. And outside of that, I'm working on building kind of the solution that I wish so many of my female patients that I saw coming out of the pandemic had access to sort of give them more touch points, more education, more care, more support. And, the company is called Systole. It's a virtual clinic for women's heart health, that is completely run on group medical visits, group virtual visits. And they're medical appointments where groups of women, 10 women see a doctor like me working alongside a health coach for 60 minutes at a time, unlike those short little appointments we were referring to earlier that frustrate us, honestly, as much as they frustrate patients. And so, with that time, we really get into the questions, answer them, educate people, build community, peer support, and everyone gets some one-on-one individual time for medication titration. So we're really excited. We're seeing patients in Massachusetts, and we're getting ready to expand to other states as we get into the later months of this year. But, to your question, how can we, what does awareness mean? Like what should we really be focused on and when? And I think that, when I look at all the research that's been done on women's heart health, and, fortunately there's more and more now, although it's, still, we have a long ways to go. There's more and more. I think the first thing to start with is just recognition of what blew some of our patients away when they're sharing their stories, that cardiovascular disease is the number one cause of death among women. And, getting to your awareness question, Natalie, like still today, we are actually seeing declining rates of awareness of that reality. And so the American Heart Association actually did a study on this, looking at women's awareness of heart attacks and heart disease as the number one cause of death versus all kinds of cancer versus breast cancer. The awareness of heart disease as the number one killer went down by like 25%, whereas breast cancer, that misconception, almost doubled. So it's really interesting to see that the numbers are kind of moving in the wrong direction on awareness. When are the times that we could potentially intervene there and draw women's attention to their heart health? I think that the times tend to overlap most with where the risk really accumulates and where it sort of spikes. And so, two distinct chapters. One is during reproductive age, and the second is during midlife, kind of around the menopausal transition. And of course, menopause isn't a moment, it's a very long transition for some. And reproductive age, it's not just the moment you have children or become pregnant. That also, with the advance of, reproductive assistive technology, is also becoming longer and longer, right? But what we know during those periods of time is that there are lots of women-specific risk factors for cardiovascular disease that emerge during those chapters. So for young women who are of reproductive age, it's polycystic ovarian syndrome, which increases your insulin resistance. It's infertility, which has an impact on your heart disease risk. Lots of things related to pregnancy. The most notable are what we call hypertensive disorders of pregnancy, like preeclampsia, which increases your risk of heart failure by 4-fold and your risk of cardiovascular disease later by 2-fold. And other, and then gestational hypertension, gestational diabetes, which increase your risk of heart disease down the line as well. So that is an opportunity, to not just talk about conception and getting pregnant and the pregnancy and postpartum, like weight loss and sleep and everything. It's not just about that. Of course, being a mother, those are very big deal topics, but it's also about, are you at risk now for heart disease down the line? And what can we do to try to bend the curve? People are living longer, women outlive men. So there's a lot of life left to live. The second big moment where risk increases and where we would love to see awareness increase as well is during menopause, during midlife. This is a time when there's a lot of biological changes, most simply put, like the withdrawal of estrogen, that leads to a host of cardiovascular challenges or cardiometabolic. So fat increases, like, especially fat that is deposited on organs, which, really increases our risk of heart disease. Weight gain, of course. So many of my patients come in and just say, oh, I started going through menopause and everything, everything on the scale just sort of went in the wrong direction. We also see cholesterol, the good, the good kind, the bad kind go in the wrong direction. Insulin resistance increases, blood pressure increases. So these are the moments when risk increases, and when we as physicians and as patients, or, just concerned, family members looking out for our friends, for our loved ones, should really be paying attention to heart health in women.
How much, when we're in those phases, so you're talking about, reproductive age and then the menopause age, how much can we control, or how much is it that we have to rely on some help with lowering the blood pressure?
And medications and such.
Yeah,
It's a
medication.
Great question.
Yeah, and cholesterol too, right?
Great question. Well, I'll first say, to your point about genetics, I mean, I think that as public sort of awareness and discourse around genetics increases, it's been very interesting as a physician to just see more patients, wondering about to what extent are genetics playing a role in XYZ heart problems that I have. And one of the most important genetic components of heart health that is really emerging as a topic here and has a, a sort of important role in women's heart health is something called Lp(a), which is a type of cholesterol that physically resembles LDL cholesterol, traditionally villainized as the bad kind. But it's stickier, and it's also sneakier in that there's such poor awareness on the provider side that people aren't necessarily checking it. It is very genetically linked, and it's high in 1 in 5 people and an independent risk factor. So, I'll just first address that, whenever people wonder about genetics, and if any of you yourselves are wondering, increasingly our field, cardiology, is moving towards screening everyone for that Lp(a) one time. So that's an important thing. But then in terms of how much can I control versus how much might I need the assistance of medications, the first thing I will say is that a lot of patients, and honestly doctors too, who end up being patients later, we get into a little bit of a mindset of either meds or, non-medical approaches. And the reality is that we're blessed to have tools in both domains, and that a both and approach is the most successful one. So I think that when women are really trying to curb their risk of heart disease, I think the most important things first are just to assess, what are my risk factors, right? And so that gets at diagnosis, checking the Lp(a), having an updated cholesterol panel, knowing what your blood pressure is, not just in the office when we're stressed and we're rushing and we're nervous about what the doctor says, but at home too. Knowing your family history. These are all important things. Then if it's determined that you are high risk, the next set of questions is, okay, well, what can I do? If you're high enough risk, then really striving to lower your cholesterol as much as possible. Every sort of 1 unit decrease in your cholesterol, the LDL kind, decreases the risk of major cardiovascular events by 22%, which is crazy, crazy. So lowering cholesterol where applicable, really lowering blood pressure. And just to put some numbers there too, major cardiovascular events, if you go down on your blood pressure from just the low 130s to the 120s, you reduce your risk of those events. Catastrophic things, that we heard about from Saraa, heart failure or heart attack, a stroke, by 30%, really remarkable. They seem like such small numbers, but they make such a big deal, they have a big impact. Blood sugar needs to be great. Weight, we've gotten used to as a society, 70% of us are overweight or obese. And I say us because it really is our society. And so we've gotten used to, and I think doctors often feel a little awkward about bringing up the topic. And I saw in the chat that, some doctors even bring it up indelicately, but trying to address that in a sensitive way and optimizing all of these things with meds, where needed, is critical. Then the next thing, very much more in our control, are things on the lifestyle front, how we're nourishing our body, movement, stress, sleep, substances like alcohol, hate to be the bearer of bad news, but it is. We increasingly as a field see it as a poison for the heart. But, I think movement is probably one of the lowest hanging fruits. Just brisk walking, we call it moderate intensity, the kind of walking where you could hold a conversation, but it might be a little breathier. 22 minutes a day, 7 days a week, that is a solid dose of physical activity that if you're a heart attack survivor, cuts your risk of having another heart attack in half. That's more than what an aspirin can achieve. So I think it's a combination, and we really try to understand and appreciate the patient's values, their philosophy, some unique considerations, a family history, a recent family member diagnosis, like in Patty's case, to help tailor our recommendations. But the reality is that all of these things can help.
It is really silent. Like, I had no idea, other than being vigilant and, vegan and all the things, but I had no idea that my blood pressure, I didn't feel it, I guess. So
Right.
what are some things that we can do to be aware of that? Because it is silent.
Yes, we call high blood pressure the silent killer. 1 in 2 adults in the United States have high blood pressure. Most don't know it, at least half don't know. And there isn't a huge difference between men and women there. Women actually have increased sort of awareness and treatment. They're kind of a little bit more dialed into this than men, but still the number of women who have been diagnosed, have been treated, and are at goal is around 20-25%, So, and it is a really big deal. Like, just taking your numbers, like the 150s, if we can move the needle down to the 120s, that's cutting someone's risk of major cardiovascular events by 60%. So, how do you know? Well, I can tell you how you don't know. It's by the doctor's visit blood pressures. Can't stress enough how often we see higher numbers there because of all the things. Maybe they just had coffee because it's the morning, or they're rushing in, they've battled traffic. If you're in Boston, my goodness, they've battled traffic to get there. They're nervous. We actually call this the white coat effect. A lot of patients just get anxious and nervous about being in a healthcare setting, and that's totally understandable. So what I always tell patients who have, an elevated reading that isn't sort of an emergency, like in the 200s over 100s, is that I really don't care what their blood pressure is in the office. I care more what it is 99.9% of the time that they're not in front of me. And so what we usually recommend is monitoring at home. It doesn't have to be something you do every day, like brushing your teeth, but I tell people 7 days of your life, 2 readings, 1 in the morning, 1 in the evening, with a blood pressure cuff that goes above the elbow, because those are more accurate. Ideally before physical activity, coffee, meds, and food, and then just send it to me. And some of my patients are very into my Excel, and they make color-coded spreadsheets and everything. And some of them write cursive on a piece of paper, and they take a picture and send it. But the average of those 14 readings gives us a rough sense gives us a good sense, actually, a better sense than if we were to just rely on office blood pressures of where you're living. And if that is too high, greater than 130/80, then, we start talking about lifestyle measures. Sodium reduction is a big one, exercise, all those things, as well as medications where needed. But monitoring is the biggest thing. And a very exciting development that is coming and already available in Europe is the innovation around how we monitor. So some people have blood pressure cuffs at home, some don't. They've become more affordable in just retail pharmacies, but there are cuffless, wrist-worn blood pressure monitors that are already, in commercially available in Europe, that just passively take readings, based on the velocity of blood going through your arteries. And there's a software algorithm that estimates your central blood pressure. It's quite accurate, and it's taking many more readings, every 2 hours. So, and it doesn't require you to do any setup and wear an uncomfortable cuff and everything. So that will also help. But I think the key thing is monitoring at home.
I think that is key. And I have become kind of, I'm like the patient that you were describing with the spreadsheet. Like, I'm always like, okay, this morning it was this, and then it was that. And, I start analyzing, well, how did I feel it like I want to get in touch with that. You are doing something so interesting, and I think it's just amazing the way that you're working with patients. You mentioned at the beginning, but can you talk a little bit more, because you've had really good success with
Yes.
patients in doing this different approach. I would love for our
Yes.
audience to hear that, and then we'll go to Q&A. So tell us a little bit.
Absolutely. So, I think, patients and doctors alike have been on the sort of frustrating side of trends towards shorter and shorter appointments, right? And why is this happening? It's because there are fewer and fewer doctors, a lot of doctors are retiring, or honestly are just becoming so burnt out, frustrated with our crazy healthcare system. And so, the solution has been to try to do more with less, and, create more visits in a business day by shortening the appointments. For example, it used to be that we would get an hour to see a new patient, which is appropriate. You really want to do a deep dive and get to know everything about them, and 30 minutes for a follow-up patient. And I think, that now feels like a luxury. I do know there are still hospitals that do that, but we now see at the Brigham and Women's Hospitals, 40 minutes for a new patient, 20 minutes for follow-up. And I just had clinic on Tuesday. And if one of my patients that I already know has had any kind of activity, any kind of news, hospitalization or some side effects, that 20 minutes goes by really fast. At another hospital, Johns Hopkins, my colleagues there have told me that their appointments have now moved towards 30 minutes for a new patient and 15 for a follow-up. It's just, it's not fair to patients and doctors. And I think what I realized coming out of the pandemic, I was just feeling that frustration on behalf of my patients too. Like, it's not fair to them. They're coming with questions. It's the most important part of their day. And we just have no time to really help them. So I learned about this model called group visits or shared medical appointments. It's actually been around since the 1990s. And it's been tested in a whole number of chronic conditions like diabetes and obesity, high blood pressure, but also things like cancer, survivorship, or chronic pain. And, what the idea is to sort of, just reinvent the way we're delivering care. Just make the time, do something radical and innovative to make the time, allow people to really be educated, to get their questions answered, to get access to the care, medication titration, labs, et cetera, but also to find community. And so the structure is, as I was saying up at the top, and in case anyone joined late, we take care of groups of patients. So, 8 women together who perhaps share a diagnosis or a similar type of heart health related concern. And they meet together with me and a health coach. And we open up with, 10 minutes of education, which, believe me, exceeds what we're usually able to achieve in a normal visit. And it might be about blood pressure or cholesterol, or, what are the new treatments in obesity, like the GLP-1 medications. And then the health coach sort of takes the baton, does a lot of teaching around lifestyle as it pertains to the topic, facilitates a discussion where women are helping each other, hearing each other's stories, celebrating the successes and troubleshooting the challenges. And in a breakout room, just like on a Zoom like this, the doctor meets with each woman for a few minutes of very targeted medication management. So it might be the blood pressure meds going up or down, or GLP-1 medications going up or down, statins, et cetera. And, it is reimbursable by insurance, just like any old visit. So that makes it more accessible. And so it's been around for a while. People have piloted it here, piloted it there. The reality is it's very challenging for hospitals and health systems to layer this on to a whole operation of these one-on-one appointments. So Systole is meant to, really create a center of excellence around virtual group care. And we're focusing first on women's heart health just because of the unmet need and the size of the unmet need, as well as some, really unique considerations around just getting women together and some of the magic that can happen when women come together as a community. So that's what we're doing, and it's exciting. We've been testing it out. Have had great retention. We've helped some women sort of figure out things like, should they be on a statin, or how do I monitor my blood pressure at home? What is my quantifiable, like, cardiovascular risk over the next decade? things that just really exceeded their appointment times that they had had in the past year. And it's been very rewarding. And the best part is just seeing them connect with each other and form these relationships and help each other. So that's what we're doing. We're very excited.
I love this so much because Patty knows, like I reach out to Patty, who's also a registered nurse, by the way. So a patient and a registered nurse, and I'll text her and I'll be like, okay, so what do I make of this? Sometimes you need that, but having the group opportunity and having someone that you can reach out that maybe in that interim phase really helps the health outcomes. And I can only imagine. And I'll ask this one last thing, and then we'll bring our panel back and have questions. But you had mentioned that one of your colleagues had really good results. Can you talk about what the
Yes.
results were with
Yes.
doing this?
Absolutely. So, my colleague is Dr. Jacob Mirsky. He's a primary care physician as well as like a leading voice in lifestyle medicine. And he has been a pioneer locally in these shared medical appointments. And what he found in a group that was specifically focused on hypertension was that he was able to lower the top number, systolic blood pressure, which is the blood pressure in your vessels when the heart is squeezing, as well as the bottom number, the diastolic blood pressure, which is the pressure in your vessels when the heart is relaxing. Both matter. It's, we often neglect the bottom number, but both matter for heart disease. And he was able to show significant reductions in both while increasing the rate of BP control, which is important. And what was interesting is that with all the lifestyle education that he was able to provide with his coach, they were actually able to de-prescribe in 50% of cases and reduce pill burden. So better outcomes, fewer pills, lots of great education and community. And this, similar outcomes have been shown in terms of diabetes control in diabetic patients, or reducing heart failure admissions, or getting the cholesterol down. And of course, just increasing patient awareness and giving them an experience that they rate highly in terms of satisfaction. So we have a lot of data that it works. It's just under leveraged because, quite honestly, we don't get trained to do it, and there's a lot poor provider awareness that it's a thing. So we're trying to make it a thing and try to decompress the healthcare system so that it can, healthcare can be what patients and doctors need it to be.
I think this is so just, I use the word disruptive, but it really is. And it's where we would all like to be. And I'm going to bring, I'm just going to add a spotlight for Priya and also for Patty, because I'd love to have all of us here answer questions. If you have a question for any of our speakers today, pop it in the chat. We'd love to hear from you, but I think what you're doing is so amazing. And I'm going to turn it over to Priya because she might have a question for you already as we're waiting on some questions coming in. But I know that this idea of group coaching combined with medication management is amazing. So Priya, do you have any questions?
No, Simi, I was just going to ask, how receptive have larger organizations like hospitals been to sort of working with you and trying to integrate this group concept into how they deliver care? Because ultimately, if you can make that connection, right, it gets scaled faster and broader.
Yes, and definitely would love to get your in-depth perspective on that later. That could be a whole other webinar, right? Priya's career working with hospitals and health systems. We're in the process of talking to a number of them, and what's been very helpful is that these are powerful revenue generating opportunities, not out of patients' pockets, but from insurance companies. So, you bill for these just like you would any old follow-up visit. And when you're titrating meds and reviewing labs and, they have multiple sort of comorbidities, it's sort of at a level of reimbursement that doctors are honestly like always being sort of asked and pressured to try to bill for. So, we think it'll work for health systems that are in a traditional like fee for service environment. But we also think, we know that it helps them with other things that they care about, right? Like improving clinical outcomes and expanding access access. So many, I'm booking as a cardiologist into like mid to late 2025 for a new visit, and a colleague of mine at UT Southwestern who works in weight management, if you already see him, if you're already his patient, it takes 2 years to see him again. You might see a nurse or registered dietitian, which is important, and it's a team, of course, but to see your doctor again, 2 years. So creating more access is critical, and I think those are some of the big things that we're talking about with health systems, as well as with specific sort of strategic concerns clinically, like preeclampsia, postpartum hypertension, as well as, like obesity with all this GLP-1 stuff. There's an interest in trying to create more access. So yeah, but that's a great question.
Talk more about that offline, but there is a question in the chat, which is, what is the greatest risk factor one should mitigate to prevent heart disease or cardiac arrest? And I know you talked about it being a combination, but if there were one, what would it be?
I think, oh boy, it hasn't been looked at this way. I feel like I come from a hospital that has led the charge. I mean, has really been the center for a lot of the cholesterol and statin and other advanced cholesterol treatment research that has gone out into the world. So I know my colleagues and senior mentors would say cholesterol. But, as a general cardiologist, really interested in cardiometabolic disease, I do think excess weight is kind of a common route for so many of the major risk factors, right? It's the blood pressure, the cholesterol, blood sugar, all of these things really accelerate heart disease. And so I think weight, especially now in an era where the treatment options and possibilities are rapidly expanding, I think is the most important to not leave unaddressed. Because oftentimes I treat a patient with, say, Ozempic, their blood pressure comes down to the point that I have to take them off blood pressure medicines. Maybe we take them off some, or lower the dose of certain cholesterol medicines. They might not need their CPAP anymore. I mean, it really helps with all of the other risk factors.
Good. That's really helpful, I think. And we have another question here. Beyond having someone push and advocate on your behalf, what else would you recommend for getting the attention of your physician when it feels like they're not listening? And I would say physician or healthcare provider, or when you're at, going for help and seeing someone taking you seriously, especially obviously with heart health. It's so important.
I would have to say that if someone's not taking you seriously, then you need to talk to your tribe and find another physician, because it's, you're going up against a wall if they're always going to have the same approach to you. And it's hard. I mean, I specialize in oncology, but there's like, if I have people that call me in the Chicagoland area and ask to see who should I see, there's just a list of a small number of people that can really connect with you, like Simi does. I mean, and that's the kind of healthcare that you want, especially with heart health. You want someone who connects to you, who listens to you, and advocates for you, and kind of cuts through the bullshit too, in a way that says like you've said you're exercising, but what does your Fitbit say, or what does your Apple Watch say? So how much is really truth versus what we tell ourselves sometimes is fiction. And I think that plays into Dr. Simi's components as well. But if they're not taking you seriously, leave. I'm sorry, that's the only way that you can change your healthcare and your physician interactions.
I think that's absolutely true. You can always switch physicians, and I'm sometimes delicate about it when a patient's telling me about a negative interaction they had with a colleague, and trying to remind them that is a power that they have. I will say, from the physician side, some things that have helped, that I see helping are, because these appointment times are so compressed, if a patient messages me through the portal before a visit to just say, hey, I want to talk, I'm looking forward to the visit and I want to spend time talking about X, that helps first of all, it's not a face-to-face, interaction. Some people find it easier to just bring something up digitally or virtually, but it just, that's on the agenda now, and so I'm going to make sure to address that as I prepare for clinic. The other thing I heard another physician mention as a tip was to just sometimes ask a question. Sometimes I think people feel self-advocacy can feel very abrasive, and certainly physicians can experience it that way. They shouldn't, but they can. And just saying, hey, do you want to hear about my obstetric history? Do you want to hear about my, preeclampsia or my menopause history? It's just less threatening, but it helps you really steer the conversation. So those are just two quick tips.
I think it's also important, like what I do is also write my questions down ahead of time, and I think
Oh, yeah.
From the point of Melanie who asked the question, it's like I tell the doctor what's important to me. That's what I start with. And then we see if we can go from there. So it's important to me that, I lose more weight, that I can keep my blood pressure active, that I can be active, and that's something that physicians sometimes ask, but not always. But you can be a self-advocate by bringing that up first.
Such a great conversation. We have great comments. We have a young audience. Well, I say young because I'm I'm obviously older than the audience member who asked about being in her 20s and asking questions. And what I'd like to say is that we are right on time, but we will share some good tips and information for you in a post email to you. I want to thank all of our speakers and excited about things that are positive. I think having programs like this and partnering with Priya Bhathija, who always lifts me up and inspires me with all the things that New Health is doing. So make sure you follow her. And also all of the people that we had on our panel today, we had all the information. We will share out the links. And it's really important to all of us that we advocate for our heart health, and your health matters. And on behalf of all of us at HEALTHX, we are on a mission to improve health outcomes for women. And so if you have any questions about our nonprofit, please scan and find out about us. We'd love to have a conversation and partner with anyone here about how to improve things the way that Simi was talking about. That is exactly the direction that we want to head in. More time. We believe if patients can have more time with their physicians, better health outcomes can happen. And that's why we're quantifying the cost of medical gaslighting. So thank you, everyone, for being here. Thank you, Simi, Priya, and Patty, and also Saraa, who had to leave. We are so grateful to all of you for being with us today. Thank you for being here.